All right. So welcome everyone. As you join, please introduce yourself in the chat just so we know who all's on with us. I would like to introduce our speaker today, who is Priya Gopalan. Dr. Gopalan is an associate professor of psychiatry and chief of psychiatry for Magee Women's Hospital and medical director of the Psychiatry Consultation Liaison Service across 9 of the hospitals in the UPMC system. She has also been one of the faculty directors of the Psychiatry Residency's Academic Administrator Clinician Educator track since 2014. She is a faculty co-advisor to the Reproductive Psychiatry and Women's Mental Health area of concentration at Western Psychiatric Hospital and is active in teaching OBGYN residents at Magee. She has been active in programmatic development around perinatal mental health and in teaching this to others. She is on the National Curriculum for Reproductive Psychiatry Education Committee. Her interests include perinatal mental health, including perinatal addiction and dual diagnosis and trauma-related disorders, CL psychiatry, healthcare administration, and resident education. Welcome, Dr. Gopalan, and I will hand it over to you.
Thank you. Thank you so much for inviting me to do this. I am really excited to talk about this because I don't think we talk about it nearly enough, really. So thank you. I'm not going to spend a whole lot of time talking about me because Anna already gave my introduction. I am going to say though that I'm going to start out not just talking about anxiety and actually take a huge step back. I know I don't have to convince any of you of this, but I want to actually talk about the why of all of these discussions and why mental health matters in this context. Again, I know you all don't really need me to tell you this, but I just kind of want to have us all start out on the same footing. So to do that, I want to start out by talking about a case. So you all are on the front lines. You do a lot of prenatal care, you do preconception care, fourth trimester intraconception, like you see people across the lifespan. So here's an example of a scenario you may encounter. A 25-year-old G1 who comes to see you, sorry, I put psychiatric consult here, but really for prenatal care for anxiety. It says that she never had postpartum depression before, is pregnant now, concerned because her sister had an episode of postpartum anxiety with her pregnancy. She was sort of wondering how common these conditions were: postpartum depression, postpartum anxiety, kind of the whole run of it. I'm sorry if you can hear the siren in the background, but I hear an ambulance going by. So what are you going to tell her? What do you tell her about postpartum depression and postpartum anxiety? How common are they? Any guesses? Call it out though, because I can't see the chat.
Probably very.
Yeah. Very is a very good answer. So I'm going to say I don't have any disclosures for this talk, but I do have a disclosure that I steal a lot of infographics from online. So I've tried to credit them wherever I possibly could. But this one is from the Maternal Mental Health Leadership Alliance, which has really great materials. But these are common conditions, right? So 1 in 5 individuals who give birth experience some type of mental health condition in the peripartum period. It is considered one of the most common complications of pregnancy and childbirth. So it's really, really quite common. And the other big why, I think, for why I do the things that I do are related to this. And we were talking about MMRC work before everybody joined, but mental health conditions are the blank leading cause of pregnancy-related deaths in the U.S. Any guesses? Yeah, it's a little bit of a trick question because of the way I asked the question. But yeah, Stacey, you look like you're about to say something.
I was just gonna say first, but
yeah,
it sounds like maybe it's a trick question. So maybe
it is a little bit of a trick question because I think it depends on how you word the question. For pregnancy-related deaths, it is definitely in the top 10. This CDC sort of image says it's number 7, but if you think of pregnancy-associated deaths, and that includes, a little bit of a looser definition of what a maternal death actually is. And there are others on this webinar who could talk about this in much more detail than I can. Then that number really just goes up to number 1, right? There are a lot of things associated with the perinatal period and perinatal mental health that really directly are implicated in pregnancy-associated deaths. This is from the state of Pennsylvania, but you'll have to take my word for it that other states also really align pretty closely with this. We know that there are health disparities associated with perinatal mental health conditions. Again, I know I am talking to an audience that really is acutely aware of this, but about 50% of Black mothers will experience maternal mental health conditions. They're twice as likely to have these conditions as their white counterparts, but half as likely to receive care, which is really, really unfortunate. But it's important for us to sort of keep these disparities in mind. These disparities do persist in our state as well. The other thing I wanted to sort of talk about from a broad stroke standpoint is the preventability of a lot of these. I'm not going to make you guess this one, but in terms of preventability of pregnancy-related deaths in the state of Pennsylvania, the MMRC said 92%. So it's a pretty high number that we should be intervening on. We should be proactive about caring for, and this really lines up with national data. In fact, it's a little bit higher in terms of preventability compared to national data. So that's sort of the why, I think, in terms of why I do a lot of what I do, and I'm sure why you all do a lot of what you do related to peripartum care. So let's talk about perinatal anxiety, because we don't really do that, right? We talk about depression an awful lot, but we don't really talk about anxiety in that much detail. I told you I steal a lot of infographics. I promise this one actually has a goal in mind. So I found this on the internet, and I want to show you a couple of things on here. So it has some of these numbers that I've been talking about. 1 in 5 individuals who are pregnant and in the postpartum period are going to suffer from a maternal mental health condition. 1 in 7 will experience depression. 50% of people in poverty will suffer from a mental health disorder, maternal mental health disorder. You kind of see mental health disorder, depression, mental health disorder, maybe one reference to anxiety here, and that's really around not perinatal anxiety, but anxiety in teenagers. We don't really see the word anxiety in here a whole lot, right? And when I typed in, we were talking about Google image searching perinatal anxiety or pregnancy and anxiety, there's really not a whole lot there. And that's unfortunate because in this 1 in 5, a good number of these folks have anxiety. Mental health conditions broadly really do actually have a significant cost to society, cost to healthcare. This is from the journal Health Affairs, really great issue, if any of you are interested in public health kinds of things, from 2021, that really showed, in terms of cost analysis, that mental health conditions increase severe maternal morbidity by 50%, costs the United States a lot of money just in terms of healthcare costs, but it also does a few other things. I'm going to walk you through this graph because I know it's a little busy. And for those of you who are driving, I will try to explain it as best as I can. But what this graphic shows, it's from the same Health Affairs journal, is on the x-axis down horizontally is severe maternal morbidity per 10,000 deliveries. And the blue lines are people without the various health conditions that are listed there. And then that sort of orangey line are the people who do. So the top one is any mental health disorder, and then you'll see here anxiety disorders as the second one. And down at the bottom, you'll see trauma or stressor-related disorders, and then the other ones are depression and bipolar disorder. And really across the board, individuals who have these conditions, including anxiety, including trauma or stressor-related disorders in the peripartum period, have higher maternal morbidity compared to those who don't have these conditions. So I thought this graphic was kind of remarkable. When you look at perinatal mood and anxiety disorders more broadly, and this is how this article sort of classified it, those who have a perinatal mood or anxiety disorder have higher C-section rates compared to people who don't have these conditions. Again, just trends that you see, things that increase morbidity, things that put people at pretty high risk for adverse outcomes. Any questions so far before I move on? That was sort of broad strokes, but we're going to go into a little more detail. Okay, so I'm going to sort of take the default stance that just in general, psychiatric illness is detrimental in pregnancy and that these conditions need to be treated. I used to have to sort of justify that stance, but I don't think I really need to anymore, but that's sort of the place I'm going to start from. I know that you all are primary care. I scoured national guidelines on a lot of things, and really the best ones that are out there right now are actually from the American College of Obstetricians and Gynecologists. They really are the most comprehensive. If you are not familiar with these guidelines, I highly, highly recommend taking a look at them. They were published in 2023. They replaced ACOGs, and I'm not an OBGYN, I'm a psychiatrist. The American Psychiatric Association doesn't have any kind of guidelines yet on any of this. But these documents came out in 2023, and they are extraordinarily comprehensive. So again, if you have not looked at these, I really recommend taking a look. And they do actually go through a whole lot of different mental health conditions, and that includes anxiety. And I'm going to kind of walk you through some of the key points throughout the course of this talk. But I just want to point you in that direction. Before we delve into what the guidelines actually tell us, though, I wanted to actually talk a little bit more broadly. So what is anxiety? And for that, again, I want to use a case to sort of highlight. So you have someone who's coming to you for prenatal care, let's say it's 7 weeks gestation, asks you about staying on something that she's already prescribed, maybe by you, maybe by a psychiatrist, but for the sake, the sake of this case, let's just say prescribed by you, sertraline 150 milligrams daily, and she's also on low-dose hydroxyzine. And these medicines have kept her stable for a pretty long time. But given that she's early in her pregnancy, she says, you know what, I think I'm going to stop my medicines because, I did have really bad postpartum anxiety last time, but, these are antidepressants. I've never really been depressed, so I don't really feel justified in staying on these medications during pregnancy. So I'm going to open this up to you all. What do you, first of all, do you see this scenario at all? Do you kind of encounter people who come to you and are like, I'm going to stop my meds, or come to you after having stopped their medications? I saw someone nod. Again, I have a double screen going here, so I may not be able to.
All the time.
Yeah, all the time. Yeah, the OBs tell me the same thing. What do you do when this comes up?
I mean, I think that there's more than one answer, which is probably the tricky thing. And while you're giving this talk, sertraline 150, it wouldn't stop, right away on its own. I think it's important to have a conversation about risks, benefits, about SSRIs in pregnancy, with the benefits probably outweighing the risks. And I would caution against coming off of an SSRI if it happens to be working, even without a history of depression, without having at least some sort of, other type of engagement with therapy to manage symptoms that are likely to progress during the pregnancy related to life changes or hormonal changes across the pregnancy, and then certainly into the postpartum period. I would also maybe suggest that if she came off, that she should restart after delivery.
Okay. So kind of a lot of ground there in terms of, oh, and by the way, you probably have 15 minutes to do all of this, I'm sure. So, I good luck. But any other thoughts? We're going to cover a lot of what you just mentioned, Dr. DeMarco, but any other thoughts?
I also think it's really interesting to hear what people think. So I often will just say, tell me what your thoughts are about that, and about whether to stop or not.
Absolutely. And Dr. Bartlett, that's such an important point because, that sort of shared decision making with patients, especially when it relates to peripartum care, is so important, right? Because otherwise, they're going to Google, they're going to see what, they're going to sort of hear things from friends or family, and they're going to sort of do their thing, right? Okay, so, just to sort of give you a sense of this, the American College, again, of Obstetricians and Gynecologists really sort of outline what they mean by anxiety first, right? Because I kind of left it vague here that she's had postpartum anxiety, but in reality, we think about a lot of distinct entities when we think about anxiety disorders. So in my mind, the very first step really is to kind of, as best as you can, try to differentiate a little bit what we're talking about when we're saying anxiety disorders. ACOG actually says, they give a few examples: GAD, panic disorder, agoraphobia, separation anxiety, social phobia, selective mutism, etc. As a psychiatrist, I will tell you that I think much more broadly than that. And not saying that you all need to or have to, but I just want you to know that this is what the thought process of a psychiatrist kind of goes through. So, we have our sort of traditional anxiety disorders per the DSM, understanding the limitations of the DSM. But we also have a lot of other categories that sort of overlap in terms of symptoms, right? So OCD often presents with a lot of anxiety, and other conditions in that spectrum present with a lot of anxiety. And, DSM-5 kind of pulled out trauma, PTSD, and ASD here as acute stress disorder. I realized a little too late that ASD is a very common abbreviation for a lot of things. But, trauma-related disorders are, present with a ton of anxiety, right? So the first sort of step really is kind of figuring out, even if you don't go through the details of every single one of these, broadly where the anxiety sort of sits, right? Is this more trauma related? Is this more an intrusive thought, an OCD, that kind of thing? So I think it's important to kind of work through that in your own mind a little bit, and to get help from colleagues if indeed it is more complicated. ACOG recommends screening. Oh, sorry. They recommend screening at at multiple time points, actually, including the initial prenatal visit. And they give a pretty strong recommendation for that, but they do recommend using a validated screener of some sort for depression and anxiety. The U.S. Preventative Services Task Force, and I'm sure you are very familiar with these guidelines, also recommends screening for anxiety disorders. They give it a Category B recommendation that adults be screened for anxiety disorder, and they actually say that that includes pregnant and postpartum persons. So I thought this was kind of interesting, but they do actually comment on this population specifically as well. Why are we screening? Well, the reason is that these are common conditions, right? Although it's a little bit fuzzy, I would say, in terms of how common they are. The National Comorbidity Study from decades ago said that about 1 in 4 adults, all comers, adults, met criteria for at least one anxiety disorder. But these, the estimates and the epidemiological studies on this are pretty broad. So, we have something like maybe 5% for phobias, 3 to 7% for perinatal OCD. And, you see the numbers here, they're kind of all over the place, right? So it's really pretty hard to really say, how common anxiety kind of as a whole is in the peripartum period. I have to tell you, I created like 3, 4, 5 slides on the neurobiology of anxiety. They were beautiful. You have to take my word for it. I had like images and like MRI and this and that and like neurotransmitters. And then I realized that you all probably really don't care as much as I care about that kind of thing. So I took it all out. You're welcome. And instead, I just left this one in. And that really is just to say that we know that anxiety during pregnancy has potential adverse effects, right? So, I think Dr. DeMarco, somebody said risk benefit, but we actually, know that anxiety in and of itself conveys risk during pregnancy, right? So we have studies that implicate untreated anxiety with obstetrical complications, things like preterm delivery, low birth weight. We know that anxiety during pregnancy, and this is based on actual human studies, may actually interfere with neonatal HPA axis development. We know that there are probably windows of vulnerability during the peripartum period where the neonate is or the fetus is particularly vulnerable to stress and anxiety. And we know that, that there are a host of conditions that are associated with untreated anxiety, including potentially an elevated preeclampsia risk. Sort of shifting gears a little bit to the postpartum period. Again, the estimates and numbers on this are kind of all over the place, but we know that it's fairly common. We know that it's even more common in the population that at least we tend to see people with comorbid anxiety. We know that anxiety rates kind of shoot up in that population as well. So the opposite of that is also true. So postpartum anxiety also increases the risk of postpartum depression. So there's some kind of bidirectionality there too. But, anxiety in pregnancy is detrimental. Anxiety in postpartum certainly can be too. I do want you to think broadly on this one too, though, and think about what really constitutes postpartum anxiety. Like the traditional sort of postpartum anxiety is like, okay, similar to depression, increase, you weren't anxious or you were only marginally anxious before. Within the first month or two, you kind of have this spike and you sort of call that postpartum anxiety. But again, you can get anxiety from things like birth trauma, from peripartum OCD. So again, I encourage you to sort of think a little bit more broadly on what this actually means. Because again, anxiety has developmental effects. It has effects at the level of neural pathways and neural development in the baby. It has implications in terms of epigenetics, and we know that a lot of this can be intergenerational in terms of transmission. So it's important for us to try our best, at least, to be proactive and get ahead of it. So what is the bright side now that I've sort of talked to you about all the doom and gloom? The bright side is that anxiety management is actually quite similar to depression management. So you all already probably are quite familiar with how to manage depression and anxiety outside of the peripartum period. You're probably very comfortable with managing depression in the peripartum period. Anxiety management is very similar. Similar in terms of risk factors, similar in terms of treatments, and overall strategies. So speaking of that, the risk factors, again, are very, very similar to depression risk factors. I'm not going to read off this list, but you can sort of see that these are fairly intuitive, right? So things like childhood abuse and trauma, IPV, sleep disorders, so inadequate social supports. The ones that I think are notable and particularly important are actually, NICU admissions really significantly raise postpartum anxiety risk. It doubles the rates of postpartum PTSD compared to people without a NICU admission. So really sort of hearing about the delivery experience and the postpartum experience, and if the baby was in the NICU, is important to ask about. Any questions about this list? I think most of these are fairly intuitive. Okay. Again, just to reiterate, untreated depression and anxiety associated with a variety of adverse consequences, including potentially poor bonding with the baby, which has its own implications. So I'm going to sort of reframe our discussion, and instead of sort of thinking about this as a risk-benefit discussion in pregnancy, I really want us all to sort of be thinking in terms of risk. So, there are these potential risks of medications, and more, at least for medicines like SSRIs and SNRIs, we know that these are pretty minimal risks, weighed against the pretty known risks of untreated illness across, a variety of different domains. Again, I'm not going to read through these lists, but you can kind of take a look. And in the field of perinatal psychiatry, at least, we really do sort of formulate our conversations with patients in this way. Like, we have the risks of the medications, but we also have the risks of not treating. And you should be aware of both of these risks, because that's, that gives you the most information to make the best choice for yourself. In other words, there is no risk-free option. Okay. Any questions before I talk about management in a little more detail? And we'll talk about specifics as well in terms of OCD and PTSD and some of those more nuanced, maybe kind of conditions. Questions, comments? Okay. All right. So let's talk about management. And I'm going to bring it back to ACOG because I just think it's easier. It's all in one place. But American College of Obstetricians and Gynecologists says, strong recommendation, despite low quality evidence, for selective serotonin reuptake inhibitors to be used as first-line pharmacotherapy. They do say that both SSRIs and SNRIs are effective for the treatment of generalized anxiety disorder, and they recommend against benzodiazepines overall. They said that they should be avoided or prescribed sparingly. I highly agree with this. I'm sure you all do too. If you're going to use benzodiazepines, it should be as a bridge, either to, bridge to other types of treatments, bridge, and while you're waiting for the SSRI to work, if at all possible. I understand that you are often in very challenging situations with patients, but as best as possible, should be used as a bridge. And patients, of course, should be educated that psychotherapy actually has a stronger evidence base for anxiety management than benzodiazepines do. So, and definitely for insomnia, there's a much stronger evidence base for psychotherapy and CBT and CBTI and that kind of thing. So I know this is easier said than done, but unfortunately, this is sort of the recommendation. So that said, if you do need to use a benzodiazepine, the safety profile of these medications in pregnancy is actually fairly reassuring, with the exception of maybe a couple of studies that have implicated their use with things like obstetrical complications and respiratory suppression in babies. So, in terms of like congenital malformations and things like that, they're actually overall fairly reassuring studies. Okay. One thing I really want to point out, I'm not going to do a deep dive on SSRIs and safety and all of the different, potential risks and benefits of benzodiazepines. I wanted to keep this more kind of broad strokes, but I do want to tell you that most studies related to medication use in pregnancy really compare two groups. So they're usually some type of case control or some type of retrospective analysis of a database that has a group of people who are not depressed, not anxious, and we're really not depressed. Most of these med studies are not in patients with anxiety, but they're usually on, a group of people who are not depressed and not on medications, and they compare them to a group of people who are depressed on medications. They're often huge databases out of Scandinavia or the NHS or like a Medicaid database or whatever. And this is kind of an apples to oranges comparison. And why is it an apples to oranges comparison? Anyone know? What group are we leaving out? The pretty critical group. Sorry, I'm going to pause for a second there. There's a group that we're leaving out, and that is what I sort of like to think of as the group that's kind of suffering in silence. So you're comparing people who are not depressed and on medications to people who are depressed and on medicines, but we don't really have a way to really measure in these large database studies the people who are depressed but not on medicines. Although I will say studies that have come out in maybe the last 3 to 5 years have tried to account for this group in some way. Because of this, any study that you see related to medications and pregnancy, almost 100% of them will have some level of confounding by indication when they report their outcomes. So I just want you to be aware of that. The better studies will do things like correct for depression severity, correct for the indication for why the medication is being used and restricted to actual like mental health conditions. But by and large, this is what you're going to see, whether we're talking about depression meds or anxiety meds or antipsychotics or whatever it happens to be. So just keep in mind that no matter what, you can try to control and correct for some of that confounding, but it's always going to be there when you have this sort of comparison. Okay. So, kind of going back to just practical tips. First line treatment, if you just, do this, SSRIs and SNRIs and evidence-based psychotherapy, in as much as you have access to it, that is the gold standard treatment for anxiety disorders, really across categories. In addition to that, you can also consider, especially for individuals who either have difficulty accessing care, for whom resources are not as readily available, who maybe can't afford resources, you can consider a more stepped approach, or for people who really just don't want to be on medicines no matter what, you can consider a more stepped approach to care and try some lower cost interventions like kind of self-care and social supports first, escalate to therapy, and then escalate to meds after that. So this is, I thought, a kind of nice way to sort of think about this. And the other thing that we talk about a lot in psychiatry, understanding that this may or may not help for our more complex patients, is NEST, not to be confused with our NEST IOP for our Pittsburgh area folks, but nutrition, exercise, sleep, and time for self. For people with more mild illness, this can actually be sufficient, or at least a way to adjunctively kind of manage symptoms. There are multiple types of evidence-based psychotherapies available for the management of anxiety disorders. I am going to make the statement that we really have to be very cautious about therapy and how we talk to patients about therapy. The evidence-based treatments are things like cognitive behavioral therapy, interpersonal therapy, mindfulness, acceptance and commitment therapy. These are the ones that have been studied. They are very specific, they're manualized, and most people do not have access to very high quality evidence-based psychotherapies. So, I've made it a point now to everyone who I see and I'm recommending therapy, make sure you find someone who is well trained, make sure you find someone who actually has expertise in doing one of these evidence-based practices. And if you're not getting from your therapist what you need, it is absolutely okay to tell them what you need. If you don't want to just be that person who, if you don't want your therapist to just sort of listen and kind of hear you vent, it's okay to say, look, I need something a little bit more directive, like CBT. I need something that, that forces me to like actually do some homework and that kind of thing, right? Because CBT and IPT actually rely on a lot of work outside of the sessions too. Does that make sense? Okay. All right, so coming back to our case, I think we've already covered a lot of this already, but coming back to this individual, this is someone where you would probably really want to outline, like, look, antidepressants are not just for depression, they are also for anxiety. And while you've never had depression before, you have had anxiety, and these are the risks that are associated with that untreated anxiety in pregnancy. And then you can kind of talk through the different options. And if, you know, if she still wants to come off the medication, that's absolutely fine, but, you know, she should do it with all the information at hand. And know that pregnancy is a period where a lot of people stop their medications. So this is a very old paper. I think it was, I want to say it's from like 2000 or something like that, from the late Adrienne Einerson, who's just a phenomenal force in the perinatal mental health world. But, you know, she sort of wrote about the risks of discontinuation of medications during pregnancy. And I thought it was interesting because there has been data since then and studies since then that really look at pregnancy as like a decision point for a lot of people in terms of medication discontinuation. So while we have actually had an increase in the prescription of antidepressants during pregnancy as a whole in the United States, and you can kind of see that line curves up, you know, over time, that the people who are on their antidepressants before pregnancy, that top line, is still higher than the number of people who are on antidepressants during pregnancy. So there's a fair amount of discontinuation, and only 1 in 10 women actually receive consecutive prescriptions for antidepressants at the beginning of their third trimester. A lot of people discontinue their medications, and so there's, you know, all of the sort of implications of that across the course of pregnancy. Not to mention the fact that now you have multiple sort of risk exposures over the course of the pregnancy, both the risk of I'm sorry, I'm like not wording this very well, but you have multiple exposures during pregnancy, the exposure of the medication, but also the exposure of the, you know, the illness itself, if indeed they have a recurrence of their anxiety or depression. So, you know, this particular article, the author said that pregnancy was a key determinant for stopping antidepressants. And I just thought that was so interesting and something that we should be thinking about proactively in anyone that we see who's on an antidepressant for whatever indication. For you all on the front lines of primary care, it becomes all that much more important, right? Because these sort of decisions and conversations ideally should happen before someone becomes pregnant, if indeed you have the luxury of being able to have those kinds of conversations before they become pregnant. Okay, so shifting gears just a little bit. You have 29-year-old postpartum patient who comes to your office and is very distressed because they're developing intrusive thoughts about harming her baby. And the thoughts have caused severe anxiety, guilt, and avoidance behavior, such as refusing to carry her baby alone and compulsively checking his crib. So she's had disruptions in bonding with her baby, disruptions in caregiving. She's, you know, kind of exhausted, and her family's kind of exhausted because, you know, she's so fearful and she's feeling isolated. So what do you do in this case? How do you explore this one, or how do you manage this one? Any thoughts? Any thoughts or ideas?
I actually had a situation like this not too long ago, where a mom came in and was like, her depression was worsening and anxiety about checking in her baby and stuff. And I kind of normalized it first with her and just talked with her about, you know, like, it must have been a really scary experience for you having these thoughts, but we can help. And I think it depends on if they were on a medication or if they did stop their meds, but, you know, telling them that, like, we can help with that, and this is not like, this is something that she can feel better from, and medications are available and close follow-up is available, and making sure she has like supports at home and safety at home.
Yeah, absolutely. So like normalizing, you're not alone in this. This is hard. Like what you're going through is hard. And let's talk about what all your options are. Any other thoughts or anything that sort of jumps out at you about the case? Maybe about the intrusive thoughts? Anyone worried about those harm thoughts that she's having? This one's kind of an interesting case, right? So intrusive thoughts can be a red flag for perinatal OCD. And in particular, intrusive harm thoughts should definitely sort of raise your radar for really screening and exploring whether someone has perinatal OCD or postpartum OCD in this particular instance. So 50% of people with perinatal OCD will have some type of unwanted thought about harm. This does not mean that they are at high risk of harming their baby. In fact, the risk of someone with harm obsessions and harm-related OCD actually acting on harm thoughts, according to our OCD expert, is actually pretty minimal, if not almost zero. So I think that's kind of important to know in the background. Not all harm thoughts require a quick sort of response. Most of the time they require some exploration. In this case, an intrusive thought about harm can be just a normal finding, or it can be a symptom of OCD. So normalization is absolutely correct in this case. Perinatal OCD is very, very common. Perinatal OCD outside of sort of the harm experience can be around a lot of different things. It can be around contamination. It can be around checking. I've had patients who will just obsessively go and check baby monitors, obsessively go and check to see if their baby's breathing. Some element of that is normal, like I said, in terms of intrusive thoughts, but if it's impairing their functioning, if it's not allowing them to sleep, if it's keeping them from being able to separate from their baby for any period of time, then it might be a sign of actual OCD. I think it's a very, very fine line between kind of normal anxiety and hypervigilance, anxiety kind of more generalized, and actual OCD. So just, I just wanted to sort of put that out there. Oftentimes the compulsive behavior is something like checking or reassurance seeking from family, or avoiding, like in our particular case. Those compulsions tend to bring the anxiety down quickly and in the moment, but then kind of reinforces that cycle of engaging in whatever that compulsive behavior tends to be. But just be aware that reassurance seeking and avoidance can actually be an OCD symptom in and of itself. I like these, like I said, I like infographics. This one is from the International OCD Foundation. This is a great free resource for any of your patients, not just your peripartum ones. So I just want to sort of bring your attention to that particular resource. I look at it all the time because they actually have a list of people who have a list of therapists who have OCD expertise in terms of management. But they do have infographics too, really great informational sheets and infographics about perinatal OCD. So I just wanted to sort of show you what some of these numbers are. It's common during pregnancy, it's common during postpartum, and we almost never ask about it, right? We don't really automatically screen for it. We don't really even think about it. And, outside of the peripartum period, this is actually the reason that OCD is the psychiatric condition that probably has the longest time period between symptom onset to diagnosis. The average is about 13 years, which is horrific. But, it's just that we don't talk about it enough. We don't ask about it enough. We've sort of long thought about OCD as being anxiety related because people are so anxious and distressed when they have their intrusive thoughts. But in terms of neurobiology and in terms of just pathways, neural networks, it is actually a distinct and different kind of phenomenon. So I just want you to be aware of that. Again, thankfully, a lot of the treatments are similar. There are a couple of exceptions, but overall, you're in pretty good shape if you start with an SSRI. So in this particular instance, that is what you're going to do. You're going to start an SSRI and you're going to refer to CBT. OCD specific CBT is called exposure response prevention. The SSRI sort of pearl that you all need to know is that patients with OCD often require higher doses, sometimes above the FDA maxes that you see, and longer treatment trials before you sort of throw in the towel and go to the next one. So I can't tell you how many times I've seen people who are sort of hanging out at like 25 or 50 of sertraline. In fact, they should be on 200 or 250. The sort of family involvement and not just for supporting the patient, but also supporting the family, also very, very important. And thankfully, this patient did well. Okay. Any questions about OCD before I shift over to talk about trauma? I know we're covering a lot of ground here, but I thought these were all important topics, and I couldn't figure out what to eliminate, so I just included it all. So you all are probably more familiar with this than I am. This is not perinatal specific, but I thought it was very relevant to what you all do, so I included this infographic that I found on the CDC website. Trauma is the #1 cause of death for people, 46 years of age and under. It is a huge sort of cost to the healthcare system. It accounts for, over 200,000 deaths, and a lot of sort of disability, and is a high sort of cause of ER visits as well. So so there's a high cost again to individuals and to society when it comes to trauma. Those numbers, of course, are not peripartum specific. These are from the National Curriculum in Reproductive Psychiatry. I did take their slides. So I want to be sure that I credit them for this information. And by the way, if you don't know about the National Curriculum in Reproductive Psychiatry, it is a free resource. It's really aimed towards psych residents, but it has a lot of teaching and training materials that are totally free. All you have to do is just register into their website, but there's no cost to that. But I digress. You all know this already, I'm sure, but trauma can look like a lot of different things, and birth trauma is a significant component of a lot of people's experiences here in the United States. As many as 1 in 3 rate their delivery as significantly distressing here in the US. Of these, significant minority, so it's not like huge numbers, but it's still a significant amount of, probably around 5% or so, who actually develop straight up postpartum PTSD. But of course, there are a number of people who are sort of in that spectrum without meeting full criteria. In the United States, there are a lot of pregnancies that end in loss in some capacity, whether it's spontaneous abortion or stillbirth, or an elective abortion. And there are studies that have some sort of suggestion that PTSD can come from some of these conditions as well, particularly the stillbirths and spontaneous abortions. So just be aware of these numbers. There's not a whole lot of kind of guidance in terms of how to screen for trauma in the perinatal period. Unfortunately, I wish that we had a little bit more to sort of help us. But generally speaking, you can think about screening for trauma and stressor-related disorders prenatally and after, especially a traumatic delivery, but maybe after all deliveries really, because you don't know what someone is going to perceive as being traumatic. Certainly in patients who've had medical complications or obstetrical complications, NICU parents, you can sort of use your common sense since there isn't a clear sort of guideline on this, and there are some validated screening tools for perinatal PTSD as well. I'm not sure that all of these are free. I couldn't tell you that off the top of my head, but at least we know that some of these tools exist. You all are more familiar with, trauma-informed care principles than I am, I'm sure, but that we should be approaching everyone with a trauma-informed care lens and framework. This involves a lot of different things. I'm not going to sort of go into a lot of detail on this because it's not necessarily peripartum specific, but also probably things that you get in other spaces. But the SAMHSA sort of principles here that of safety and establishing trust and trustworthiness and giving people as much choice and autonomy as possible, especially in the immediate aftermath of a trauma, to sort of maximize collaboration and promote empowerment is really, really important. For me, I do a lot of hospital-based work, so I think about what we can do in the immediate aftermath of trauma, and that includes traumatic deliveries, and that may or may not include involving a partner. It depends on the situation and what the patient desires, but that can be helpful potentially. Oftentimes, I will tell you with that traumatic delivery, the partner often needs some support as well, so there could be an added benefit to that. Staff continuity is always good. Restoring a sense of safety is really number 1, 2, and 3 in this sort of instance, and making sure that your hospital or your system has a good process for things like documentation of memories and contact with baby and that kind of thing, and really using patient-led language, even with words like baby, to make sure that we're not doing anything to cause undue distress. Common theme, thankfully, treatment options for PTSD are very similar to those for depression, for OCD, for anxiety. SSRIs and SNRIs first. You can consider second-line medicines like prazosin and buspirone. There is obviously less pregnancy data for both of those medications, but nothing that really has overtly linked either medication to congenital malformations or any long-term developmental effects, so I do tend to recommend them. I see a lot of patients at McGee inpatient who have trauma histories and PTSD diagnoses. And then, of course, don't forget psychotherapy. Again, especially for trauma, as long as a patient is ready for it, you don't want to risk re-traumatization, but psychotherapy can be hugely, hugely effective, more effective than medications, in fact, in some studies. So it's sort of important to just keep that in the back of your head. And because you are in primary care, I also want to mention that there is actually kind of a promising emerging body of literature around prevention strategies for perinatal PTSD symptoms. Nothing that's really jumped out, nothing that you can just sort of pull out of your back pocket right now. But there are studies looking at single session sort of interventions, EMDR, kind of for prevention, for PTSD prevention, midwife-driven sort of things, narrative types of interventions, dyadic care, and debriefing with a huge kind of asterisk of you have to be very, very careful not to re-traumatize people, but you could potentially explore that as well. Again, I think, maybe in another 5 to 10 years, we'll have more on this, but it is something that's pretty exciting. And again, the VA says don't use benzos in the immediate aftermath of a trauma or for PTSD long-term at all. The VA doesn't actually recommend benzos at all. Some other national organizations do. And then, of course, post-loss, the trauma that comes post-loss and the PTSD symptoms that come post-loss are a little bit different and really kind of overlap a lot with grief and complex grief and bereavement. So, any kind of support resources can be helpful, and careful screening for depression and anxiety and PTSD, that kind of thing is also very important. Okay. Last few minutes, I'm going to talk to you about just some resources that are available to you. I know a lot of you mentioned kind of how hard it is to access resources sometimes. So I wanted to just point out some free ones that are available that are not sort of insurance dependent or anything like that, since I heard that there are a lot of people from not just the Pittsburgh area. So UPMC has a maternal wellness program. It is free. It is not, dependent on, you don't have to be a UPMC patient. You don't have to, none of it. So you can direct patients to this website. They can register themselves, or they can email maternalwellness@upmc.edu. And there's a calendar every month that has a whole bunch of classes and support groups. The Hope group is a support group. There's a loss group, just a lot of different classes and things. And this is completely free. So I wanted to bring this up as a potential resource. If for whatever reason someone doesn't want to do that, if they had a bad experience, they just don't want that sort of thing, or if they want something that's a little bit more specialized or a little bit more specific to their identity group or whatever, Postpartum Support International has some really great online support groups, also free, extensive list, including multiple for peripartum anxiety, for birth trauma, for NICU, NICU parents, for OCD, for like all sorts of different things. So I highly recommend this one as well, especially for like anxiety, OCD, trauma spectrum stuff. Like there's a lot that is very specific to those conditions. I'm a fan of Nurture PA. I learned today that their peer mentorship program it's completely text-based, but they are no longer just doing it to the Pittsburgh area. So this is also a free resource. It is a text-based peer mentorship program. So I'm just putting in a plug for them because I think they're cool people. And most excitingly, and what I'm going to end with, is to talk to you about psychiatry access programs. So how many of you have heard of MCPAT for Moms? Anyone know about that particular program? Okay. So MCPAT for Moms was the first perinatal access program, and it is really to address the point that I think Dr. DeMarco made at the beginning, that sometimes perinatal mental health resources are really just not available. So there are 30 other states in the United States that have perinatal access programs. And actually, the state of Pennsylvania has a pediatric one for child psychiatry that's been operating since 2016. And the way our state has done it is it has divided up the state into 3 parts, with each sort of region having a separate access program for child psychiatry and now for perinatal psychiatry as well. So if you all are familiar with the TIPS program for children, we are now designing a perinatal TIPS, basically. So what is the perinatal access program? It has several components to it. So the idea behind this is to really make sure that you all have access to perinatal mental health expertise and someone that you can kind of just pick up the phone and talk. I like to sort of think of it as having a perinatal psychiatrist in your pocket. So, our program is going to provide education. I know the Children's TIPS has conferences periodically. We're hoping that we will be able to do that as well. There's going to be a 9 to 5 perinatal psychiatry consultation phone line. This is sort of aimed towards medication questions, that kind of thing. But obviously, we're not gonna hang up the phone on anyone. So if you have questions that are beyond just medications, we're certainly going to be able to help you. And care coordination is going to be a really key component of this. We are going to have a perinatal mental health specific care coordinator to help with some of these resources in case, you don't have sort of the time or bandwidth to just like list off all of the different resources I just showed you. And for those individuals who are diagnostically complex or where you're not really sure, is this depression? Is this peripartum OCD? Is this harm thought, psychosis? Is it OCD? Is it anxiety? We are going to offer, not yet, but, hopefully later in the spring, a one-time kind of 2-part telemedicine visit for diagnostic clarity with a therapist and then a psychiatrist. We are going to serve the same counties that Western Pennsylvania, that the pediatric tips pediatric tips program covers. For other parts of the state, Penn State has the contract for Central Pennsylvania, and then on the eastern side of the state, there's a collaboration between CHOP and the Philadelphia Department of Health, I believe, and they are going to have the contract for eastern Pennsylvania. So I don't have the numbers for them off the top of my head, but there are this is going to be covered across the state. And what a workflow for this could look like in your office from a very practical standpoint is, if you're seeing a patient and you have a question about, a psychiatric need, a substance use disorder need in pregnancy or in the postpartum period, you may realize that you have this question before you see the patient. You might realize it as you're seeing a patient or after they've left. You can initiate a call and a consultation to the perinatal tips program, calling the number. It's the same number as our pediatric tips program. And you can make this call yourself, or you can have someone from your team sort of initiate it, but the person who answers the phone is going to be a care coordinator, and that will be a real-time sort of answering of the call between the hours of 9 and 5. That care coordinator will ask you when you want to talk to the perinatal psychiatrist. We usually try to do it same day, but certainly by the following day. And there will be like a provider to provider, physician to physician, whatever discipline to the psychiatrist kind of consultation. And there are a lot of potential outcomes. I know some of you probably are already familiar with this model, but it might be a simple like, can I increase this person's med? Yes, might be really straightforward. It could be, actually this person has a lot going on. Let's also add some care coordination. Or what, I'm not really sure. Why don't we bring them in for a telemed evaluation? So this is an example case. I know we're sort of running low on time, but I promise I'm almost done. Example might be someone who's on aripiprazole for bipolar disorder, also on a bunch of other medicines, and she's on 5 milligrams. She wants to increase her dose. You're not really sure of the safety profile of aripiprazole in pregnancy, especially at higher doses. This might be a way to just get some reassurance on what you can and can't do in pregnancy. I didn't include the slide that actually says what the program isn't, so I will say this is not a program where we take over prescribing. We're not going to take that patient's care from you. We will give you recs that you then execute, but we can certainly help to give you sort of the recs to bridge until people get into care, whether it's at McGee Behavioral or your local perinatal mental health clinic or your local community mental health clinic. We can sort of help you to manage people until they get to care. So I'm putting up the number here again. If you would rather not use this, there are also some national numbers that are there as well. There's a national line with Postpartum Support International. I think there's one through the federal government. There are a few that are available. And then of course you all know these resources from a medication standpoint. Otherwise, I'm going to stop there. Any questions? I'm going to end with staying on the slide just because it has the number. If anyone wants to take a picture of it or wants to put it in their phone, I'm just going to kind of leave that there. But any questions?
I have a question, if you don't mind. Thank you so much for that. That was super helpful. I really appreciate it.
I'm going to stop sharing with you.
Yeah, it's always easier to actually see faces, right? So one of the sort of tenets of what we do in implicit and in fourth trimester specifically is do this sort of pre-planning in the third trimester for the postpartum period. And one of the questions that is on our sort of standard questionnaire is about birth trauma, which is kind of what prompted me to ask you to talk about it. So thank you very much for doing that. It's essentially like, have you experienced birth trauma? And I think one of the things that we're not quite sure that some folks, including myself, sometimes are not quite sure how best to handle that conversation. So I was just curious if you have any ways that you ask the question maybe differently, or things that you try to things that people might tell you that you might try to, any guidance you have in that space would be fantastic.
You know, that's such a great question. And I'm going to tell you what I do. I'm not going to say whether or not that totally aligns with some of those screeners that are there, just for full disclosure. My question around birth trauma is actually really more broad, because I've found that a lot of people don't really either understand what the word trauma means, or they've had so much of it in their life that it becomes almost a normalized experience. And so, you know, what we may perceive as being traumatic, they may or may not. And sort of the flip of it too, what we may or may not see as traumatic might actually be for someone who goes through their delivery. So what I usually ask is actually, you know, can you tell me about your delivery experience more broadly, and see where that leads me? Because if they tell me, oh, you know, it was awful, but I kind of got over it, I'm okay, then that's one thing. But if you sort of ask it generally, and they're, you know, they either freeze up, or like you sort of see an avoidance, or like, you know, or people get emotional, you can sort of explore that more. Like, that sounds really scary. Do you think that was really, you know, would you consider that to be traumatic? Like, you know, you can sort of follow that up with kind of more detailed questions. But yeah, my sort of initial question is just like, tell me about your delivery experience. How did that go? And see where that takes me. And then if they kind of, you kind of sometimes get the shrug of the shoulders or whatever, then you might follow it up with like, did anything happen that was really scary, or did anything happen that was concerning to you? And then sort of follow it up with maybe more specific language around trauma. But my opening questions for when I talk about birth trauma is always extraordinarily broad, because of both of those extremes, right? Of people either perceiving trauma as kind of a normalized thing versus something that we would maybe consider not traumatic, that other people might see as being very traumatic.
Yeah. Thank you, Maria. I like that question. And that's what I usually do, and sort of, because I try to make it like, how am I going to actually do something with this information? Like, I'm not just asking just for you to disclose things, but like, what can I do with that? And so I'm usually trying to think like, okay, how can we kind of mitigate things to, or change things in some way to help in this next delivery. So
is that the question that we have? It's something like that. I was trying to think about how we ask it, but
I just put it in the chat. So did you experience any physical or emotional distress during or after a prior childbirth that you would like your care team to know about?
Pretty close.
I think those are great.
Yeah, it's pretty good.
Yeah, we have a question around birth trauma that's more provider facing on like just like complications from previous births. But then this question is meant to be the patient facing one, to just give them the opportunity, because I think similar to what you discussed, their definition of trauma may be very different from a provider driven definition of trauma.
Absolutely. Yeah, I think the more open-ended, with the understanding that you will eventually sort of go into more detail, the better. But I think both of the things in the chat look really great.
Awesome. Okay. Thank you.
I just want to say thank you for sharing those resources that are available outside of an institution. I think that's one of the barriers, is that every sort of delivering hospital, or health system has its own thing, and every health insurance plan has its own thing, and every county has its own thing. And so it's really nice to have a series of resources that are helpful or even local, but that are not only accessible by people with, a UPMC login or something like that.
No, I totally get that. And you can thank Dr. Fedoroff and Dr. Bartlett for this, because they prepped me ahead of time that it wasn't just the UPMC audience. So I appreciate that. And I'm happy to share my slide set as well, if that would be helpful.
Yeah, if you would send it to me, I'll send it out with the recording of this as well. And then that way it's easily packaged together for the network. Thank you very much. It was great. We greatly appreciate having you present, and appreciate everybody who was able to attend. And I hope you all have a good rest of your evening.
See you. Nice to meet you all.
Thank you.
Bye.
Thank you so much.
Thanks. Good to see you, Priya.